Yes, I'll go through just the management and treatment with regards to late onset hypogonadism. As Marinka went through now, late onset hypogonadism, or the definition, is a clinical condition in aging men. It compromises both persistent symptoms and with biochemical evidence of testosterone deficiency. It's more prevalent in males above the age of 40. Between 40 and 80, the incidence varies between about 2 to 5.7%, and there's higher prevalence with specific populations: diabetes, metabolic syndrome, obesity, cardiovascular disease, COPD, chronic kidney disease, and other cancers. It's important to distinguish between organic and functional causes, just to say that functional hypogonadism is a diagnosis of exclusion, so you've excluded others and normally associated with obesity, comorbidities, and aging. And overall, the standard is that the free testosterone declines about 1% per year after the age of 30. So specifically indications for treatment. So like I mentioned, it's patients who are only symptomatic and have biochemical low testosterone. So the EAU used 12, and she mentioned others used 10. 2 or more occasions. And just in terms of the follow-up, the patients need to respond to testosterone therapy after 3 to 6 months in order for you to continue treatment. But that's more during the follow-up. The specific symptoms that they used in or that came up in all the trials, the T trials specifically, and the EMAS, etc., they noted that all of these patients specifically had reduced libido, erectile dysfunction, and decreased spontaneous morning erections. With regards to contraindications, so the absolute contraindications are prostate cancer. I'll go into more detail regarding these. Locally advanced and metastatic specifically, breast cancer, desired fertility, uncontrolled or poorly controlled cardiac failure, a hematocrit more than 54%, thromboembolic events that are acute, so less than 3 to 6 months. Relative contraindications are severe low urinary tract symptoms, which have IPSS scores of more than 19, family history of thromboembolisms, and a baseline hematocrit between 48 and 50%, where with this specific group, you need to optimize the cause of the increased hematocrit prior to starting treatment, or be aware of it during your follow-up. So COPD and obstructive sleep apnea are the main 2. Testosterone treatment outcomes. So with regards to sexual dysfunction, the benefits are only seen in hypogonadal men, and I think this is reiterated throughout my talk, as well as all the studies in their conclusions, and not in eugonadal men. Erectile dysfunction, there are better outcomes in the more severe hypogonadism compared to the less severe, and especially during the T trials, they showed there's an overall improvement in the sexual activities. Regards to body composition and metabolic profile, they noted increased lean mass, reduced fat mass, and improvement in insulin resistance, with the improvement of weight, decreased weight circumference, and lipid profile, but the findings are not unique. Mood and cognition did seem to improve. Milder depressive symptoms. With bone, there's improved bone mineral density, but the information related to the fracture risk is lacking. And then with vitality and strength, they did note that the 6-minute walking distance increased by more than 50 meters. But if you took the total population in the study, then there wasn't a significant difference. So, sorry, I forgot to mention with the sexual dysfunction, the first line treatment in symptomatic hypogonadism is testosterone therapy in mild erectile dysfunction, and you can use testosterone and PD5s in the more severe erectile dysfunction patients. They have a better response. With regards to your treatment choice, so firstly, remember the goal is to maintain a serum testosterone concentration that's within normal ranges. A supraphysiological testosterone level does not improve symptoms more, and you need to evaluate the patient throughout to see if they actually had an improvement of their symptoms on the treatment. Take into account the availability, safety, cost, tolerability, efficacy, and the physician and the patient preference when starting treatment, and select the treatment option and preparation with a fully informed patient, and it must always be a joint decision. I think they reiterate this as well throughout all the specifically American studies, because I think they are being sued quite often with regards to testosterone and cardiovascular events. Lifestyle factors and others. So firstly, like Marinka mentioned, you need to go through all the primary and secondary causes and rule them out. And then obviously treat, when indicated, an organic cause of hypogonadism like masses and hyperlactinemia. Improve the patient's lifestyle and reduce the weight. So exercise, low-calorie diets to lose weight, stop smoking. That mentioned, these only have a small improvement in testosterone levels, about 1 nanomole per liter was noted, but with cases of patients that had significant weight loss, and through bariatric surgery, they actually had a more than 10 nanomole per liter increase in testosterone. So withdraw drugs that can impair the testosterone production, treat the comorbidities before starting treatment, and then treat the other abnormalities, bisphosphonates for osteoporosis, antidepressants for decreased mood, depression, and then PDE5s that come into play with erectile dysfunction. Side effect profile of these medications. So overall, fluid and electrolyte disturbances with water retention. Polycythemia is probably the most common side effect. Liver toxicity, more on the older preparations. Infertility, because there's a negative feedback of LH and FSH. Azoospermia is present in about 90% of patients at 10 weeks, and there was a rebound of normal fertility was seen about in 18 months, but not in all patients. Cholesterol, so the total and the LDL cholesterol remain the same, but there's a decrease in HDL cholesterol. I must say that in some of the studies actually contradict these statements, but overall, I think it's inconclusive what they actually do to cholesterol, because most of them say that the total is decreased. Some say that the LDL may increase, and definitely the HDL decreases, but there's also mentioned that the triglycerides may increase. So it may worsen obstructive sleep apnea, does not cause sleep apnea. And then lastly, gynecomastia and breast tenderness, because there's increased estrogens due to aromatization. So just to go through the specific treatment types. So the oral preparations, we have testosterone undecanoate, which is esterified with long chain fatty acids, and it's absorbed through the lymphatics, mostly bypassing the liver. They have a poor bioavailability, and there's a strong dependence on dietary fat content. They have to be taken 2 to 3 times daily. The dose is adjustable, so that's one advantage, or easily adjustable. But the unpredictable absorption with the dietary fat intake does not play in its favor. Misterolone is a 5-alpha dihydrotestosterone derivative. It's not aromatized properly. It's used short-term with painful gynecomastia, and whenever you type it in, it always comes up with the anabolic steroid users that use it for gynecomastia. So parenteral, yeah, we have so they normally peak at about 72 hours. There's a lack of circadian rhythms, and also they talk about the testosterone crash. We have obviously they peak at 72 hours, then they decrease for the time before you actually re-inject the patient, where they get a sudden increase of testosterone, and they can become irritable, and the symptoms may obviously worsen at that time of their trough. So the short-acting preparations, which very short-acting is testosterone propionate. And for these patients, so it's normally a BD dose, so 12 hourly. It's low cost, very short acting, so you can withdraw easily. Relative small risk for polycythemia, which is the main risk for these parenteral medications. And normally when to check the testosterone levels for these patients is after 3 to 4 cycles, just before your next injection. With the long acting, so Nebido is what I was used to before. Normally these patients normally get a 6-week loading dose, then every 12 weeks, and you need to check the trough testosterone level after 3 to 5 doses. Another guideline also mentioned that you need to take it halfway between the second and third 10-week cycle. But I think overall you just need to see the patient gets adequate levels and actually need to repeat or what the levels are before you repeat dose. Side effects here can be mostly polycythemia, and here it's long lasting, so you can't withdraw easily. Less frequent administration is obviously a great advantage for these patients. Injections are many every 3 months, but you can use it to every 10 to 14 weeks. Then lastly, all the other short acting are also mentioned there. We at Tigerberg, we have access to testosterone cypionate, which is depot testosterone, and the recommended dose is 200 milligrams every 2 to 3 weeks, and you can increase or decrease it as you monitor the patient. With regards to the surgical implants, so these have, you need to check these every 2 to 4 weeks. Initially after 2 to 4 weeks, you need to check the dose and if it's correct. And then at 12 weeks, you need to check if you actually need to give the patient a next dose, or can they last, some can last up to 6 months. So these pellets are inserted subcutaneously, 4 to 6 of them. And the local or the disadvantage is that it's an invasive procedure. The side effects can be that there's extrusion, there can be pain at the site, infection, hematoma, and they can migrate. Transdermal preparations. So gels are the first choice and most widely used in the USA. It is quickly absorbed by the stratum corneum, creating a reservoir within the subcutaneous tissue, and then the testosterone is continuously delivered for 28 hours or 24 hours. You must check the peak testosterone after about 2 to 4 hours to see that you have an adequate dose, and you can increase or decrease it as needed. With regards to patches, basically also the same, a daily patch that you insert. They recommend that when applying the gels or the patches, you do not apply it on the same area on consecutive days. And with the patches, there's less contamination or of other people. It may cause local skin irritation, and with the I think then the last preparation, the underarm testosterone, we also have where you can squeeze it into an applicator, and then there's also a daily dose. Most of these, or all of them, are daily doses. Lastly, with the dihydrotestosterone gel, is normally used in painful gynecomastia and in patients with microphallus. So these mainly have local skin irritation and those effects. With the transmucosal, so you get transbuccal, which is sustained released mucoadhesive buccal testosterone tablets. They can cause gummy edema, blistering, and gingivitis. Advantage of these is that it's a steady state of testosterone, minimal fluctuation, and you can withdraw easily, but it can cause possible irritation, gum edema, blistering, and gingivitis, and you need to remember to actually do it twice a day. The tablet does not dissolve completely and needs to be removed. Transnasally avoids transfer, and it's normally a 3 times a day nasal dose. Gonadotropins, so these are mainly used in patients who you want to preserve fertility. in secondary hypogonadism, and then off-label use by other anti-estrogens, selective estrogen receptor modulators, and aromatase inhibitors, arimidex and clomiphene, and as well. And here, that was interesting, or shocked me a bit when I read it, was that they're actually made from urine of pregnant women. They extracted there. That'll make me remember it. So with these off-label medications, please remember that they could predispose men to thromboembolism, and these agents can lead to reduced bone mineral density and osteoporosis, potentially increasing the fracture risk. So when you do use it, remember to inform your patients. Safety and follow-up. So we'll go through these: hypogonadism and fertility issues, male breast cancer, LUTS, prostate cancer, cardiovascular, erythrocytosis, and obstructive sleep apnea. So hypogonadism and fertility issues. Like I mentioned before, exogenous testosterone, it inhibits gonadotropin secretion by the pituitary gland. It impairs spermatogenesis and sperm cell maturation. And you use gonadotropins to increase the testosterone and restore sperm production. Alternatives is clomiphene and arimidex. Okay, and then with regards to male breast CA, in vitro and in vivo studies have clearly documented that breast cancer growth is significantly influenced by testosterone and or by the conversion to E2. So through different mechanisms and pathways. So these SERMs still represent an important therapeutic option in the management of this cancer. And basically these are, so treated in active male breast cancer is an absolute contraindication for testosterone therapy. Obstructive sleep apnea, there's no evidence that testosterone treatment result in the onset or the worsening of sleep apnea. And in a study that actually noted that a combined therapy of CPAP and testosterone gel was more effective, but it was a small study that they just mentioned. Yeah, it's important that you must note that if throughout your workup of these patients, you should, and before starting them, you should ask for symptoms of obstructive sleep apnea and ensure that they are treated prior to starting testosterone treatment. Lower urinary tract symptoms and BPH. So it's thought that prostate growth is dependent on the androgen presence historically, because testosterone therapy was thought that it would aggravate LUTS in patients with established BPH due to that fact. However, with the preclinical and clinical data, there's low rather than high androgen levels may decrease the bladder capacity, alter tissue histology, and decrease the ratio of smooth muscle to connective tissue, which impairs urinary dynamics. There's no difference or improvement of LUTS and IPSS scores, and there's increased prostate size, no difference in flow or post-void residual and PSA. Here, multiple studies have different outcomes, but in conclusion, with the EAU guidelines, basically the conclusion was that there's no difference in LUTS. The only concern for these patients with severe lower urinary tract symptoms, so IPS is more than 19, because they are usually excluded from the randomized controlled trials, and we don't have any sufficient evidence for these patients. In prostate cancer, so there's very low levels of testosterone cancer, have a reduced risk of developing low to intermediate grade prostate cancer, but they have non-significant increased chance of developing high grade prostate cancer. These were demonstrated in those three, or found in all three of those trials. There's no increased risk of prostate cancer in hypogonadal men undergoing testosterone therapy. You must avoid testosterone administration in men with advanced prostate cancer. Because there's insufficient long-term prospective data on the safety of androgen administration in prostate cancer survivors. If there's an occult prostate cancer, if it's not detected before initiation of testosterone therapy, the treatment may unmask a cancer that's detected with early rise in PSA over 6 to 9 months of therapy. So in two of the guidelines, they stated that more than 0.6 or more than 1.4 on 2 occasions in total. So first, when you do find an abnormality, you need to investigate the patient first before you start treating them on testosterone therapy. And the abnormalities that you should look for is obviously a clinical. On your digital rectal exam, you find a nodule. If the patient has a PSA more than 3 in a high-risk group, so first degree relative and African American descent, or if they have a PSA more than 4. So in summary, in prostate cancer, it should be restricted to patients with low risk for recurrent prostate cancer, PSA less than 10, Gleason score less than 7, clinically at T1 to T2A, and you should start the treatment at least 1 year after 1 year with the follow-up PSA levels of less than 0.01 nanograms per milliliter. In specifically with regards to radiation, in external beam radiation and brachytherapy, they haven't clearly made the guidelines. They just say that if there's no evidence of recurrence of the prostate cancer after 1 to 2 years, you can potentially give the patient testosterone therapy if they are symptomatic with caution. So it's not in the guidelines as it. Cardiovascular disease and CCF. So late onset hypogonadism, the question remains, is it a cause or consequence of atherosclerosis? Is it, it is associated with cardiovascular risk factors, so central obesity, insulin resistance, hypoglycemia, dyslipidemia, and prothrombotic tendencies. And these patients with a chronic inflammatory state, all of these may contribute to increased cardiovascular disease risk. The studies revealed no increase in major acute coronary events, which include instant death, MI, stroke, etc. And they reported an improvement in cardiac ischemia, angina, and functional exercise capacity. And these were over 3 years, 3-year follow-up data. In cardiac failure, so it is contraindicated in men with severe chronic cardiac failure because of the fluid retention that may lead to an exacerbation of the condition. But interestingly, untreated hypogonadism had increased the readmission and mortality rates in men with heart failure. So yeah, in conclusion, or overall, there's a definite benefit in symptomatic hypogonadism to treat these patients with testosterone therapy. If you have a patient with moderate chronic cardiac failure, they may benefit from low doses of testosterone to keep them in the low or the mid to normal ranges. And if you do decide to treat patients that have cardiac failure, they need regular clinical assessment, serum testosterone, and hematocrit. So more closer follow-up, you need to take out your stethoscope. Erythrocytosis. So elevated hematocrit is the most common adverse effect of testosterone therapy, more so in the parenteral than in the other forms, in the gels or the oral. Any elevation above the normal range for hematocrit normally becomes evident between 3 to 12 months after testosterone therapy. However, it can also become evident with any subsequent increase in testosterone dose, switching from topical to parenteral treatment, or development of another comorbidity, respiratory or hematological disease. There's an increased risk of venous thromboembolism, or they say that it peaks at 6 months and then it declines. But in that specifics was a smaller study that they noted this increased risk. 40 out of 42 cases had an underlying thrombophilia. So this is why before you start treatment, I think it's worth asking the patient if there is a family history, and if so, to investigate them prior to starting treatment. If you do have an increased risk, or if you do have an increased hematocrit, it's more likely to more likely to occur if your baseline level is towards the upper limit of normal before you initiate treatment, and if you have added risks at baseline like smoking and respiratory conditions. So what do you do If a patient presents with polycythemia or high hematocrit, you need to take into account if this patient does have other comorbidities or risks of acute cardiovascular event or thrombus. And in these patients who do have a high risk, you withdraw first. You reduce the testosterone dose. If you reinitiate, you can change, or you need to change the formulation. And if it was very high, you can consider doing a venesection and actually repeat it. Usually, if the patients aren't at high risk, you don't need to withdraw treatment completely, and you can just use these measures. With regards to follow-up, main thing to remember is the goal of testosterone treatment. So you need to maintain a physiological testosterone concentration for these patients. Then during the T trials, they clearly showed that the benefit, and specifically the improved sexual symptoms, were present as early as 3 months after treatment, and ensure that the benefits from the treatments are actually there within the first 12 months, so 6 to 12 months of treatment, and consider if you need to continue the treatment, obviously, if it does not benefit the patient, although they have low testosterone levels. In prostate cancer, so in the patient group that's with the age less than 40, they have a low risk of prostate cancer. Above 70, the mortality risk is not high enough to warrant monitoring. So if you do decide to do PSA screening in this age group, you need to discuss it with the patient. Overall, the parameters that we follow up, so with each visit, so initially at baseline, then after 3 months, after 6 months and 12 months, and then annually. You normally do so symptoms, weight, waist circumference, digital rectal exam, patient's blood pressure, other comorbidities, biochemistry, check the PSA, hematocrit is important, the testosterone levels, and then the lipid profiles. Instrumental, so the DEXA scan for the bone mineral density, they say that you should do it at baseline, and then again at 18 to 24 months, and then as needed in future, to see if they actually had an improvement. And that is it from me. Thank you very much.
Thanks so much, Dr. Groble, for an excellent comprehensive overview of the management in patients with late onset hypogonadism. I just want to see if there's any question on the floor.
I've got one question, if I may, Sam. It's about what you would use in the presence of a patient who wants to preserve fertility. I mean, am I right in saying you've got clomiphene, you've also got beta-HCG, and you've also got a GnRH analog? Which one would you recommend?
So the only recommended one is the gonadotropin, so the GnRH analog. I think the clomiphene and the other one is not clearly recommended in the old label.
And the only advantage of clomiphene is it's so much cheaper than your GnRH analog, though.
Sure.
But yeah, your point.
All right, thanks. So there's a question from Kent. I don't know if you can see that, the problem. So, sorry, Dr. Groble, you were saying GnRH would be an option. I don't know. I would think I don't really have a real answer. I'd rather sort of be more in line with Justin clomiphene, because if you give GnRH analogs, you're going to end up having a negative feedback again, which is not going to help you much.
Sure, but I think, sorry, if I can just get back to the slide, the gonadotropins are the only ones that they that were recommended. Okay. So HCG, but the other ones they just mentioned that they're off-label. But yeah, I do agree with you. Later on, they would analogs would obviously have the opposite effect.
Yeah. Okay. Because your clomiphene sachet does increase your HCG, you know, which is something you probably want, but the GnRH analogs will then castrate the patient, basically go back and cause a negative feedback, lower your testosterone, lower your you know, and LH, FSH, and then you've got problems.
Yes.
Yeah.
Yeah, that's what we use.
Yeah, no, thanks so much for that. There's a question there from Kent. In terms of cost effectivity, which one is the best?
So in just testosterone therapy overall?
Yeah.
Okay, so I think in total costs, the intramuscular injections, so the shorter acting ones, so like depot testosterone, I think those are the cheaper ones. The gels are very expensive, and although in Nabido you can argue that it's a longer lasting one, I think the price is still more expensive than using the shorter acting ones that last the need to have injections every 3 to 4 weeks or 2 to 3 weeks. So I think the shorter acting intramuscular injections are still the cheaper ones, or the most cost effective.
Right. And there's a question. Sorry. Sorry. So there's a question from Groble from Ekadeha. He's asking, any comment on topical use of testosterone in management of hypospadias in patients with hypospadias? Any comment on using topical testosterone?
Yeah, so I know we have what they are used to increase for microphallus and to have an increased urethral plate, but I must say I didn't go and specifically read on that. Sorry, Dr. Corley. Can't give you my opinion. I don't have too much experience with doing hypospadias myself.
All right, no, thank you so much. Yeah, thanks a lot for an excellent talk, Dr. Groble, and I'd like to thank Dr. Marinka Hook as well for a great talk this morning. So I guess in the absence of questions, we'll then see you guys in the next week. Thank you so much.
Thanks.